able to see the recording. Okay, good afternoon, everyone. My name is James Scholes. I am thrilled to have the privilege to be serving as a facilitator for the spring impACCT virtual rounds. We have some great presentations on the agenda for today. We wish to acknowledge the land on which 3CTN operates. 3CTN's work takes place on the traditional Indigenous territories across the province we now call Ontario, and we are thankful to the Indigenous peoples who have cared for these territories since the time immemorial. We acknowledge that Toronto, where the 3CTN office is located, has for thousands of years been the traditional land of the Mississaugas of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat peoples. Today, we respect and honor the presence of the many diverse First Nations, Inuit, and Métis people who make it their home. We also acknowledge that as we are a virtual meeting, that many others may be on different territory as well, so please take the time to reflect and honor the Indigenous communities of your territories. 3CTN continues to host virtual rounds to support the opening of additional sites for selected portfolio trials and to increase trial awareness across the network. impACCT virtual rounds are held quarterly, and investigators are encouraged to consider bringing forward their portfolio trials for inclusion in upcoming sessions. And as this week, May 20th, was International Cancer Clinical Trials Day, and today's session will feature one trial from Dr. Paul Toren. We also invite 3CTN's Management and Portfolio Committee Chair to join us today for a chat about the portfolio peer review. You are encouraged to submit questions at any time. Questions can be submitted through Slido with event code SPRING, and attendees can also submit questions through the Zoom chat as well. If there are any outstanding questions after the session, we'll reach out to the presenters and share those answers with you. With that, it's my honor to introduce our distinguished speaker, Dr. Paul Toren. Since 2015, Dr. Toren worked as a clinician scientist in the Department of Surgery at Laval University, where his laboratory focuses on the translational prostate cancer research. He completed his medical training at Queen's University in Kingston, Ontario, urology residency and clinical uro-oncology fellowship at the University of Toronto. Subsequently, he completed 2 years research fellowship at the Vancouver Prostate Center. So with that, please welcome Dr. Paul Toren.
Great. Thank you, James, for the introduction, and thank you for the CTN for inviting me to present our trial, the BicaBCa trial. Just give me a second here. I'm going to share some slides if it works. So you should see that. My name, I'm from Quebec City, where I've been, as you mentioned, for 9 years. And this is some work that that started in our lab here, and we've been fortunate enough to develop into a phase 2 clinical trial. And so I'm going to talk to you a bit about that, the rationale behind it, where we're at, and what we hope to obtain from it. And I'm happy to take your questions at the end of the presentation. So this works here, yeah. So I want to start out with a question. I think it's important to have questions when we're considering clinical trials. And one of the questions as a clinician who treats bladder cancer is there a way that we can harness these very notable sex differences in bladder cancer? For those of you who don't know much about bladder cancer, it's, I think, the 5th most common bladder cancer in the world. It's certainly up there in Canada as well. And it encompasses a very stark, stark is not necessarily the right word, but a very striking difference in incidence between male and female. With men typically having 3 to 4 times more the incidence than females, but females tend to have more aggressive cancer and often with worse outcomes. Bladder cancer, it can be divided into 2 main streams, non-muscle invasive and muscle invasive. So muscle invasive is bad cancer, which tends to metastasize if not treated. Non-muscle invasive bladder cancer is different, however, and it essentially can be indolent in many cases, but it has a very high recurrence rate, and about 10 to 15% of these patients overall progress to muscle invasive disease. I won't go into all of the treatments, but one of the treatments pertinent to this trial that we give as a prophylactic measure to reduce recurrence rates and to reduce the risk of progression is something called BCG, which is a vaccine actually that we put into the bladder. It was invented by a Canadian, Dr. Morales from Kingston, about 50 years ago. And since then, essentially is the same treatment, more or less, with very little differences since then to decrease recurrences for these patients. So as I mentioned, there is a difference in incidence epidemiology in bladder cancer, but also a big difference in terms of tumor biology. The tumors are not necessarily the same from some biology I won't get into. And as you all know, there's very remarkable immunological differences between the sexes, whether it's in cancer, whether it's in physiology, immunology, vaccine response. It's well known in different fields. And so can we harness that for treatment of bladder cancer? This is a phase 2 randomized trial for non-muscle invasive bladder cancer patients who are recommended to have intravesical BCG. And this is sponsored by the Université Quebec, where I'm a urologist and clinician scientist. And so I'll go over here the rationale for this. And I think there's different reasons why this trial makes sense to do and why we should try and complete it. The scientific rationale is sort of on the left. And then the practical reasons why this makes sense to push further is two aspects of cost and the fact that urologists already use these drugs for prostate cancer. So bicalutamide, for those of you who don't know, is an AR antagonist. It blocks the androgen receptor, and this may have a direct impact on bladder tumors. So we did some work looking at the expression of the androgen receptor in bladder tumors, and similar to others, found that it was highly expressed, 40 to 60% of patients, if you look at all the data. And it seems to be perhaps more expressed in lower grade non-muscle invasive tumors, showing some of our data and those from the Mayo Clinic. We also looked at this, showing that essentially it can be prognostic. This is in muscle invasive disease, but those who have muscle invasive disease, perhaps it suggests a worse outcome, although this doesn't directly apply to this study. And so I just want to mention that androgens in bladder cancer is not new. It's been around for almost as long as I've been alive, that different scientists have looked at this in bladder cancer and found that in many different models of rats and mice, that blocking it does decrease the appearance and recurrence of bladder tumors in murine models. And I won't go into much more than that. Why did we choose bicalutamide? Well, different reasons. One of them is that we had a previous grant looking at bicalutamide in bladder cancer through the Cancer Research Society. The other is a very practical reason. It's 10 times cheaper than the other new drugs that we have because it's off patent. And when we looked at it in cell culture, we actually found that it worked just as well or better than some of these other drugs. So it's not necessarily how potent it is, which is important, and we'll get into that more. And so this is some previous work in our lab and Dr. Freday's lab, where we did mice studies with the MBD2 model. And briefly, when we added enzalutamide, which is also an AR antagonist, we significantly improved not only the tumor growth, but the survival and recurrence-free survival of these tumors. And this was done with BCG when we injected in the tumor, and also with anti-PD-1, suggesting this is more of an immune response because this is actually an AR negative model, but we synergize to get better outcomes. And so with some of this data that we published a couple of years ago, we were fortunate to get some funding from CHRI to move forward. And so when we applied, actually, we didn't know that much about the hormone modulation of immune activity. We did suspect it was the case, that there was some other indirect mechanisms, but since then there's been a couple of papers, and I'll get into them. One of them was published in Nature in 2022, showing effectively that the androgen receptor itself may be involved in T-cell immune reactions and may be a limiting factor. And so by giving androgen blockade, we actually reactivate the T-cells to do their function and kill cancers. And this is showed in these two papers. This is the second paper. I won't go into too much, but essentially, perhaps some of the sex differences in bladder cancer are related to T-cell exhaustion. And by blocking androgens, particularly in male patients, we may reactivate T cells to attack the cancers and reduce recurrences. And so we found this same thing when we looked at our data. And this is with anti-PD-1. This is tumor growth, and it mirrors essentially what they showed in a different bladder cancer model called the MB49 model. And so this is some of the science behind this that we were involved with that rationalizes why blocking androgen receptor with bicalutamide makes some sense. Of course, it takes a bit more than that often to go to clinical trials, and we did a systematic review in 2020 looking at patients who, for various reasons, took medications which suppress androgens. Now, the vast majority of these are actually 5-alpha reductase inhibitors used for BPH, but some of them were also bicalutamide and or androgen hormonal therapy, androgen deprivation therapy. And so when we looked at this, there was 12 studies. Now there's 18 studies. This is a growing field. And very notably, the decrease in recurrence rate in a meta-analysis, which was published the same year as us, showed that it decreased recurrences by 54%. So that was very encouraging that this is something real. This is something that's observed. Obviously, retrospective biases here that could be seen, but it was seen only for recurrences, but also for decreasing the incidence of bladder cancer. And so that was multiple studies. And there's some small studies suggesting that the presence of the AR may be in the tumor as a marker of response. And so that helped as well to push towards this. We're not the only ones that have seen this data, but we were involved in 2 of these studies, which I'll highlight at the bottom. This study, the BicaBCa trial, and then the CHUQ study. The CHUQ study, unfortunately, didn't make it through. I'll explain that in a second. But these are some other that have been done. None of them have been completed except for one study in metastatic patients with 10 patients at phase 1. The other ones are more recently started. The one that had 1 patient in was because they had 4 urologists in 1 center. And that urologist that recruited patients is effectively semi-retired. So we hope to be the first looking at this in non-muscle invasive bladder cancer, and we're currently recruited, I think, about 35 or 36 patients. So the CHUQ study, I just want to put a shout out here, mainly from my collaborators. We received funding from the Cancer Research Society to do this study. Exactly the same rationale, except this time we're looking in, well, mostly the same rationale. We're looking at advanced bladder cancer, metastatic, where they receive an anti-PD-1, anti-PD-L1 avelumab in combination with bicalutamide. And this was to be a practical study, phase 2. But something came out last fall, which essentially said that we should use immunotherapy in first line, not the second line that we'd planned here. This really upsets the whole treatment space and makes it infeasible to do the study. And so this study died rather quickly before I got started. But I just want to shout out to the different medical oncologists who helped collaborate for this study. So this was the original design that we got funding from CIHR. It's part of a scientific grant, so this is not a purely clinical, it's half clinical, half translational research in this study with correlative science, looking at sex steroids, AR expression, and urinary cytokines relating to our proposed mechanism of action. But essentially, we plan for 160 patients to be randomized between bicalutamide and BCG, with recurrence-free survival the main outcome. We did modify this when we were fortunate enough to move some of our residual funding from the Cancer Research Society to this, because we'd already bought the placebo for the other study. And so we repurposed that placebo to make this into now a placebo-controlled randomized trial with essentially the same design, but we can obviously better assess the symptoms between the 2 arms. And so it's a 1-to-1 randomization. The main outcome is assessed during regular cystoscopy follow-ups, which these patients have about every 3 to 6 months in the first couple of years. And so again, where pathology detected recurrence is the main outcome, and this is powered to detect as phase 2, a 50% decrease in the recurrence between arms during follow-up. These are the secondary outcomes. There is correlative science as part of this, and this is a very important part of this, which we were able to further support with the SRC funding to look at, for instance, the microbiome and how it affects the response to BCG based on some data from my colleague, Dr. Frede, and also looking at urocytokines, sex steroids, how this influences the response to this treatment or not, and androgen receptor expression on the tumor samples. I'd like to thank my different collaborators on this study. We have sites open in Quebec and Ontario, and just thanks to them, we are recruiting well at our site, not so much at the others yet, but a lot of them have opened in the last 6 months, and so that's where we're at 36 patients. We anticipate overall that this trial will be the first to assess prospectively the benefit of androgen blockade and to see if this indeed decreases the recurrence rate, which is, as I mentioned at the beginning, in the ballpark of 40 to 50% for many of these patients. And so there are obviously challenges with clinical trials. It takes a lot of work to get to where we've gotten today and a lot of help from a lot of people. We hope to address some of the issues with recruitment at collaborating sites through our new protocol, some minor modifications in it. We are expanding our biobanking to really improve the science that we want to get out of this trial. And there's obviously logistic issues to work with turning this into a placebo-controlled cohort, but we'd already gone through a lot of those for the previous trials, so we're fairly well prepared. And then obviously we'll see what the interim analysis, which we have planned at 80 patients, if our design assumptions, which can be difficult in this space, are indeed hold true. And so with that, just to summarize, I think it's notable that we can translate laboratory findings to the patients, and this is what we are trying to do. This is what we hope to show, and I believe that should be done. It should be done well, carefully. Bicalutamide is a very practical option. This is one of the interesting things about this trial, is that it costs very little. It's well used by urologists in another context in prostate cancer. And if we can add this could change the way we treat non-muscle invasive bladder cancer. Obviously, confirmatory trials would be preferred, but we hope to get interesting science out of this if it doesn't work or if it works, particularly in the areas of how sex steroids impact outcomes in this patient space, immunology, and also in a newer venue of investigation as to how the gut microbiome may be impacted by these two other things. And so overall, we're working, and our lab is working, group is working to develop what we hope will be the first sex-specific treatment of bladder cancer. I might have gone over it quickly, but we are targeting male patients for the obvious reason, several obvious reasons. The science behind things, the use of the drugs, regulatory issues, it all favors in a large way narrowing our population to males. And so that's where we're at. I would like to take a few minutes to just highlight a few people, particularly Catherine Gerard, who's on the call with us, who together with Tiffany Gris have acted as coordinators of the study. Of course, a big thank you to all our patients who have participated, and also to our different collaborators and colleagues listed here, and the funding agencies as well. Of course, we can't do it without funding. And so thank you for your interest. And I'm happy to take any questions regarding the study.
Oh, thank you, Dr. Toren, for a great talk. It's great to see that you're looking at different correlative science elements for this study, especially the gut microbiome. We have a couple of studies on our 3CTM portfolio that are looking at how fecal transplantation can help with immunotherapy treatments. So it's interesting to see that within your study as well. We have some questions coming in from Slido. So the first one that we'll look at is, are there any negative impacts of the CHUQ study using bicalutamide prematurely completion on the BicaBCa study?
Sure. So the CHUQ study, I went over it quickly, but it's the same principle. It's combining anti-androgens with immunotherapy. BCG is a more general immunotherapy, whereas avelumab is a targeted immunotherapy, but we'd hope to see the response. The trial, in fact, never recruited any patients because we actually canceled the trial about a week or two after we'd received the letter of approval to conduct the study. And so it's in a very different population space. The reason for its cancellation has nothing to do with the science or the rationale for doing it, but simply the fact that there's very few patients that get avelumab maintenance therapy anymore. So doing a combination study in this space becomes very difficult, and if not basically impossible. And we tried to pivot in different ways, but you can't do what was a second-line treatment in a first-line space and expect to get results with the same number of patients. And so our options were limited. So I don't think it really impacts the BicaBCa, which is a very different population of patients. Would have been nice to have both studies to obviously compare things and see the different clinical spaces, different types of tumors if we see similar findings, but we can't, and that's what happened. So,
Thank you. So you mentioned treatment costs in your presentation. Does your study's analysis include cost effectiveness elements?
It's a good question. So no, it doesn't. And the reason we didn't include cost effectiveness is because this is a phase 2 trial. It's not a phase 3 trial. I think you must do that if you're doing a phase 3 trial these days. But for a phase 2 trial where the main outcome is to provide the first prospective evidence that this type of treatment has an impact in non-muscle invasive bladder cancer patients, it just is not necessary at this stage in the game. Certainly can be done after the fact if it's a positive study. I mean, if it's a negative study, there's not much reason to do it either. A consideration, but not at this stage. I think the cost, just as an aside, bicalutamide costs like $5 a month or something like that, and so it's very feasible. And we're doing the study. I glossed over this, but only for 3 months of treatment to specifically overlap with the BCG treatments, which are given over a space of 6 weeks. And so there's not that much time that they're on the drug, and so it's obviously going to be cost effective if you can reduce the recurrence in a patient admitted to hospital with surgery, particularly since the average age of these patients is just under 75. So it's a bit of a no-brainer at that level. But thank you for the question.
Thank you. So we got another question from Slido. It seems like this trial will be opening in quite a few 3CTN sites, so Canadian Cancer Centers. How would you like the recruiting sites and 3CTN to help overcome the challenges you mentioned?
Well, there's always challenges at different levels, and some of them are minor protocol issues that we've changed. A lot of them is just enthusiasm from co-investigators, and there were competing studies that did impact us, which when we applied this grant years ago were not an issue, but became an issue when we opened the study. Fortunately, those studies have closed, and so that's, as of now, no longer an issue, but that was an issue a year ago. And so, but it's working through all the different issues at the different sites, stimulating recruitment as best we can, but it's often different issues at different sites. And we're opening more sites. I think that's something we're fortunate to be able to do, having received a bit more funding through the Cancer Research Society, and that has helped. And so by opening more sites, we're also more selective about which ones we open to really maximize the impact at this point.
Thank you. I think this is maybe our final question, but we'll check the chat afterwards as well. But from 3CTN to Dr. Toren, this trial has received CIHR funding. Can you provide some insight into the significant factors contributing to the success of the grant application?
Sure. Well, sometimes history helps teach us a few lessons. We applied for this grant, I think, 4 times. So it took a lot of persistence. And I wasn't one to just take the comments and submit them back the month after. So it was more than, I think it was 3 years. Over the space of 3 years, we reapplied. We have to listen to the comments of the peer review and adjust things accordingly. That certainly needs to be done. And we learned a lot and we improved things a lot. Again, the panel is like another whole issue where you apply. This was not put into the randomized control panel because that wasn't the focus of the study. It was more of the science of taking this approach to the clinic. And since we have the clinic in large measure here and collaborators, that made sense to include that as part of the study. You learn a lot in the process, I would say. I don't have any magic answer for CIHR. It's challenging, especially clinical trials. We have another idea that's similar to this, which in my view is perhaps even more impactful, which we haven't been able to get funded yet. So, I mean, it's you have to be persistent. You have to have people review, take the comments that you get and improve it and reapply. But I don't have any specific magic bullet.
Thanks. Yeah, that is a difficult question to answer, but thank you for your insights. I don't see any questions coming in from the chat. I'll just give one more second. Oh, Rebecca, do you have a question? Or...
Yeah, I think you, Dr. Torrance, talking about the CHR funding is a good segue that we for the second half of the session. So yeah, it's very good that we have some of the insights from Dr. Torrance. Yeah, thank you.
Thanks. Okay, I don't see any more questions, but if we receive any more questions, we may reach out and get those questions answered. Thank you very much, Dr. Toren, for a wonderful presentation. We look forward to seeing the results of the study and the future studies coming up of CHUQ. Thank you again for your presentation.
Thank you.
As this is our 10th edition of the 3CTN virtual rounds, we like to add a new section to the virtual round, which is the chat with the chair. I'm happy to invite our portfolio team members, Dr. Joe Pater, 3CTN's Management and Portfolio Committee Chair, and BicaBCa, 3CTN Portfolio and Informatics Manager, to join us for the next half hour to have a chat. Dr. Pater is the founding director of the Canadian Cancer Clinical Trials Group. He has served on numerous research advisory boards and selection committees in Canada and internationally. Dr. Pater has received several awards in recognition of his research, most recently in the inaugural Canadian Cancer Society Lifetime Contribution Award. As today's virtual round, I'll leave it with Rebecca and Joe.
Yes, thank you, James, for your introduction. Joe, it's a pleasure to have you here today with over 10 years of your experience with us for the portfolio. So your insights are very important to us. So today we are looking forward to reviewing some of the key topics and addressing some of the common questions that we've received. So to kick things off, I will start with some questions that James and I frequently encounter. After that, we will open the floor to questions from the chat and Slido. Is that okay?
That's fine. It's a pleasure to be here.
Yeah. So Joe, so we have received so many applications. So can you name any of the trials that have stood out over the years for you?
It goes back many years. I think one of the issues we faced and this, it does go back to 10 years, the issues and sometime before your time, was we had to establish a baseline for measuring the success of 3CTN. So, and that success is really based on accrual to trials and accrual to trials that are in the portfolio, but we had to establish a baseline. We had to go back to trials that existed before we created the portfolio. And that gave us lots of issues in terms of definition and what to count, what not to count. One of the major trials, and I'm afraid I'm going to blank on the name of the trial, was that was part of this discussion, was a study in which patients were randomized to receive no, it wasn't randomized. There were patients were offered the use of genetic testing prior to treatment for their breast cancer. And that trial accrued very many patients quickly because it was offering basically something for free that wasn't otherwise available. And the issue was whether to count that study as part of the baseline. And after a lot of discussion and then with the then head of the chair, of that study, we decided that really it didn't actually count as a trial of the type we were looking for. And so it wasn't included in the baseline. So that was, if you're asking about a single trial that caused most discussion, that was probably it.
Yeah, I remember that one, and I remember the name of the trial. It's called Uncle DS. So it
Well,
is
that's the name of the test.
Yeah, that's the name of the test, and also like the acronym for that trial. And then I remember a lot of discussion. And at the time I was in Hamilton, and I know a lot of sites are recruiting quite well with that one, and really want it to
That's
be
right.
included.
You know it from the source. Yeah.
Yes, exactly. So I know that I always brought a lot of questions to you. So so from all the issues that I brought to you, so do you recall any top reasons that I sent to you?
Well, I've been thinking about this a bit. It's kind of evolved over time. Early on, we had to establish a number of definitions that are all quite clearly stated now in the application form and the explanation of the application form, but those weren't all there at the beginning. They were implemented when we faced trials that didn't quite fit with the simple, straightforward, randomized trial of a drug or other form of intervention. And so what led to questions really changed over time. I think at the beginning, we struggled with, maybe not struggled, we had to really be clear about what we meant by an interventional trial, and particularly what outcomes counted. If you look at some of the definitions that are available, probably the thing that it makes the most importance is that a trial in one way or another, like the trial we just heard described, has to intend to affect something that matters to patients and matters to the clinicians treating the patients. So we had to work around the idea of, well, what about a trial that just measures a change in a blood test? Well, it might be clinically relevant if the change in the blood tests would change what treatment the patient would get. But if it's just collecting information for further research, then it's not a trial. So early on, I think we had pretty many discussions about that. And then more later, we got into some of the issues around, I guess, it's in the definitions. Again, we struggled with what to do about what are called pilot studies that are intended to determine whether a later study could be successful. And I don't go into it, but we certainly had questions about that. But now I think most of the questions now are around the topic of peer review. We've sorted out our rules for the other studies. They're stated, and generally speaking, it's easy for you and the team to decide whether a trial fits. But sometimes it's a little bit difficult to determine whether the process that led to a study being developed and approved somewhere really fit our definition of independent peer review. So probably that's the most common question you address to the committee or to me.
Yeah. So we do keep track of some of the interesting data. So James can you also put a link there to the chat? So we have received so many applications, as I mentioned, that over the past 10 years, we have 476 trials that put into the 3CN portfolio. And actually, I asked James that before the rounds to count how many kind of trials I brought to you for the questions, and we counted 150 trials actually counted you. And out of all this issue, like what you said, that we have all kinds of questions that brought to you. And recently that the top reason is that 35% of the trials that brought to you had a peer review concerns. So that's something very, very interesting. But overall, the successful rate to add to the portfolio is still very high, about 85%. Usually the trials are very straightforward, and only the one that need to be escalated to you that we brought to you, and then we resolve those ones. So I think it come back to the peer review questions here that you mentioned last. So we know peer review is one of the criteria that we set up, and then have a lot of questions. So, but let's bring back to the questions that can you explain again why we even require the trial to be peer review in the first place?
So there's a history to this too. I guess I've been around a while, so everything is a history that I tend to remember. We think back to what led to the creation of 3CTN. It was a review done actually mostly by Elizabeth Eisenhower of the status of clinical trials in Canada. And a particular concern, there's a lot in that review, but a particular concern was that it seemed that it was getting more and more difficult to do non-industry run studies, or what we call academic studies. Meanwhile, in the United Kingdom, starting in England and then in the United Kingdom, there was a very successful initiative to support clinical trials, initially in cancer through something called the National Cancer Research Network, and then later established across all disease sites. And they have a more complex system that we do, but also a more organized system. And one of the key things was that the NCRN, which is kind of the model for 3CTN, was a support group. It was an infrastructure support program that helped clinical trials that came from somewhere else. Well, not from somewhere else geographically, but from some other agency, help those trials succeed by supplying infrastructure funding in the centers. But the issue then is, okay, what clinical trials will we support? And their model was that they will support trials that received approval through one of their funding mechanisms, and they actually had a somewhat more organized funding mechanism for trials. So they had a very simple model. If a trial was approved by one of the agencies that approved trials in the UK, it would be on the portfolio, and that's essentially the model. But that meant that those trials had gone through a process, which we call peer review, that attested to their scientific quality. And it was clear that NCRN was not supposed to be in the business of judging scientific quality. It was supposed to be in the business of supporting high quality studies. And so that model was in the original RFP and elsewhere. That was the model was adopted for 3CTN, that it was an infrastructure supporting group. It wasn't in the business of judging what was good science. It was in the business of supporting good research science. And so we adopted the principle, or the organization adopted the principle, that the trials that would appear in the portfolio were ones that had what we call independent scientific peer review. And so that's been there from the beginning. And I think it's an essential component, because the last thing that 3CTN wants to get involved in is trying to decide which trials are better than other trials. That's somebody else's, others' business. And as I'm sure you'll lead me to, the problem is that that not all trials that come to 3CTN have gone through the kind of process that you've just heard described by getting funding from CIHR or some other agency. Sometimes people manage to set up trials and find sufficient funding for the trials without having a clearly defined process for assessing the scientific merit of the trial. And that's where we run into having to do things.
Yeah, so like from time to time that we always got a question from people, such as a few questions that I may brought to you before. Then they will ask us, why can IEB review count as a peer review? They're also very independent. They also may have some scientific questions. Why IEB review doesn't count?
Yeah, it's not sure I got all of that, but it's not totally easy to define what we mean by independent peer review. But I think the word independent, so there's two components really. There's the idea that the person who's consulted on whose opinion it is that this is reasonable science has to have the expertise to say that. So that's what we mean by peer. But we also are interested in that opinion being given by someone who's independent of the project. And what do we mean by independent of the project? Well, is not directly involved in it. Obviously, if somebody's the co-investigator, they think the project's good, so their opinion on the project is not all that helpful. We also generally say that if a person is actually in the same institution as the study, where the study's coming from, even if they're not directly involved in the study, that they're not really independent in the sense that in the sense that they have to some extent a vested interest in the success of the study because it's coming from their own institution. What we really want is the opinion of someone who has the expertise to make a judgment, but isn't going to be benefited in any way by giving a positive or a negative judgment. And that's a little bit difficult to define, but generally speaking, that means somebody who's not a co-investigator on the study, someone who's from a different institution. And well, at least in our case, I don't think we have to worry very much about financial conflict of interest, but that's a major issue in other settings.
So I think maybe let me clarify again. So for the IEB, so Research Ethics Board, they also review the trial. And some of the ethics board, they may feel like they also done all this that we described. Why can't they be counted? So
that's an excellent, that's yes, so the REBs are, so, and that's something that's gone back and forth, that some research ethics boards take a strong position that bad science is not ethical, and therefore one of their roles in life is to judge the quality of the science. And other ethics boards feel that they don't have the capacity to judge the science of every study that comes before them. And I think that latter opinion is more valid than the former. I mean, if you think about it, REBs deal with very, very many studies. They really couldn't summon the expertise to judge the quality of every study. So we generally don't consider ethics review to be a scientific peer review.
Okay, that's very good to know. So, but another one that people always ask us that, so all the study that come to us are multi-center. So then before the site even decided to involve this one, and some of them already open to recruitment and they're well received. Why can we waive the peer review if they already reviewed by so many sites? And also it's kind of like has essentially been peer reviewed by those scientific or the PI from different sites. Why can we waive them?
Yeah, so that's interesting. That I guess the reasoning there is, first of all, the process for deciding whether to do a trial on a given site is not always a totally scientific judgment. It might be, somebody's a good friend of the principal investigator and they convince them to participate in the study. But again, it goes back to this concept of independence. If somebody has joined a study and that's a good, and in fact, my job in life in the past was to get people to join studies as investigators. That's a good thing. And I think it's reasonable to think that people who choose to join a study think it's a good study to do, but they're also then not truly independent Their career, if they put lots of patients on the study and get their name on the publication, is benefits by from that study. So if we're going to be strict about it, they're not independent. The decision to join a trial is not on itself a independent peer review exercise. It's sometimes a little hard to stick to the pure definition, but otherwise we get ourselves in really complicated situations where if we make an exception here, then we really should then codify that and continue to make the same exception every time we see the same circumstance, and that's not easy.
Yeah. So, but then we would sometimes we explain all this to them, then they will further comment that, oh, then it's very restrictive. It's so hard to put a trial into 3CM portfolio. Why we want to make it so hard for the PI then?
Well, I don't know how hard it is. You just gave me the numbers, but the large numbers of trials go in fairly smoothly and easily. So it's the ones on the side that are difficult. And I think an exercise like this may help explain why it's sometimes for trials that are a little bit different, a little bit not gone through the usual process, why we might make it a little bit more difficult. So, because we really, 3CTN doesn't have all the resources in the world. It has to allocate the resources in a way that supports the best science it can. But as I said before, it's not in the business of judging the science. So we need to make sure that somebody has judged the science and judged it in a way that meets the standards that are used for all the other studies on the portfolio.
Okay, it's good to know. So then I have a question always that it's more like our question. So when you mentioned about CRH grant and then Canadian Cancer Society, we usually waive them. But then I realized that sometimes they have not even developed into a study protocol. But our peer review is more about the study protocol review. But the peer review of the grant are more about their scientific proposal. Why do you think that the equivalent that we can waive them for the peer review of the study protocol?
Well, that's a good one. I guess we may have just had a slight example of that. You're mentioning the situations where we try to develop facilitated peer review, and that really only happens when there's a full study protocol developed. When I haven't sat on a CCS or a CIHR or other grants panel for some time, so I'm not sure I can answer this completely, but think that even though there's not a fully developed, fully written out protocol, granting agencies are not going to support a study that doesn't ask a scientifically valid question and have a plan to answer that question in a meaningful way. It would depend upon which grants panel you went to, whether the panel itself would want to see a whole protocol, but certainly they do make a judgment on the basis of the information provided. And when we do our facilitated peer review, we look at some very specific questions that I think you can do without a full protocol in front of you.
Okay, so yeah, that's good to know. And sometimes I also ask you to cover to review some of the protocol. Just from your experience, how long does it take for someone to review a study protocol for us that it would take usually?
I think if yes, if it depends a lot on how close it is to your area of current expertise, and generally speaking, we ask people, for example, if we just listen to talk about the study we just heard about, if that we don't need to do facilitated peer review there because it has been peer reviewed. But if it hadn't been, we would ask people who were not likely to be involved in the study, but who were involved in the treatment of patients with bladder cancer to comment. And it how long it would take them to do that kind of review would depend upon whether they were pretty familiar with some of the issues around immunotherapy and the issues around whether androgen suppression might affect response to immunotherapy. If that was really a kind of something they were working on independently, it wouldn't take very long. On the other hand, if you hadn't been interested in that particular aspect of bladder cancer, you'd have to read things a little more carefully, look at the logic, look at the supporting information. But as a general summary, hours rather than days for peer review for the kinds of studies that we're looking at, because basically clinical trials have lots of things attached to them, but fundamentally there's a single question being asked, and judging whether that question is a good question and whether the study is designed in a way that there's a good possibility that the question will be answered is a lot simpler than looking at a series of laboratory experiments that are addressing multiple questions with multiple techniques. So it's not that hard. It takes time, but not forever at all.
Okay, so yeah, I think those are the questions in my mind that we've seen. So maybe I just ask James. So are there any slider question maybe share on the screen so we can address those questions? And anyone that have one, feel free to raise your hands or unmute yourself to ask more questions to Joe. Okay, Joe, there's a question. Say, you mentioned the report on the state of clinical trials noted a decline in academic trials in Canada. Why are academic sponsored trials so important?
There's only it's so it's the only question, but it's the answer to it will probably take the rest of the time we have available. It's again because I've been around a while, I've watched the landscape of clinical trials change dramatically over well since 1980, which is over 40 years, and it's a strange story. When I became director of the clinical trials group in 1980, there was very little industry involvement in cancer clinical trials. The only company that almost the only country doing a company was Bristol Myers, which is now Bristol Myers Squibb. But and so almost all the trials that were being done that addressed important therapeutic questions were done academically and were done by organizations that were set up to do clinical trials. And that's another difference in cancer, that there were such organizations called Cooperative Clinical Trials Group that were funded both in the US by the US government and in Canada by the Canadian Cancer Society. That's job in life was to conduct clinical trials. And the questions that those organizations addressed ranged widely. They weren't all drug trials, but pretty much maybe for the first 10 to 15 years of in my career in this, those organizations kind of controlled the landscape. Now that could have been a good or a bad thing, but then the rapid increase of industry-funded clinical trials took place, and there's not time to go into why that happened. But it's the case, and there's nice documentation that something like 90% of current cancer clinical trials are industry supported. And there's nothing wrong with that. That's a good thing in the sense that the studies are, many of the current treatments we use came from trials like that. And it's advantageous to patients to have better treatments. but there's some questions that industry is unlikely to address. First of all, studies that don't involve drugs are rarely funded outside of academic enterprises like CHR, et cetera. And questions that relate to drugs, but relate to the optimal dosing, optimal duration of treatment, comparison of one kind of drug to another kind of, are rarely supported by industry, because the industry's motivation is to get a drug on the market and to sell it. And once they've got it on the market and are selling it, they're not interested in finding out whether a lower dose or a shorter treatment span would be beneficial. So I think we need people who we need studies that address questions that affect patients, but affect them not just in, is this new drug better, but what is the optimum treatment, and what is the effect of regular treatment, and that's kind of the motivation behind what was said. So I think that it's not so much that we use the word academic and it has a bad tone to it, but what we really mean, I think, is that studies that are done by are organized with a kind of a mission to improve patient outcomes in general, not with a mission to improve profits for a company. And that's so I think we need that balance. We certainly need industry. That we can't afford to do all the trials to develop drugs, but we also need a kind of balance of trials that address questions that industry won't address.
Yeah, I think you raised a very important point, and that's exactly the 3CN mission, that 3CN is supporting the academic trials, and we would like to support. And from our analysis and from all the data, that academic cancer clinical trial do cover a lot of areas in the trial area, and to improve the treatment options. So another question that I think get back to the question related to the peer review, that so a lot of people say doctors so busy, so we ask them to review the study protocol. So what are the benefits to them, especially if they're new to this field, to do the peer review? Are there any kind of direct benefits to them for the
I think
running
that I have to be short on this. Dr. BicaBCa at our institution actually has a nice YouTube video of why you should do peer review, but that's really in the context of sitting on a grants panel, for CHR, for CCS. And I personally, from my own experience, that is really important. It's one way to understand the field, one way to check your reasoning, one way to, anyway, there's many benefits for being in a group of people looking at the same study and getting other people's opinion. Now, that's at least possible for our facilitated peer review, because we have two reviewers. They see each other's reviews and they can learn something from that. I think that's probably the major advantage. You can't not learn something from reviewing somebody else's work. You always learn something.
So yeah, I think we believe the benefits here. So what advice, and maybe just the last question for me is just, what advice would you offer to the new investigator who would like to be the study protocol peer reviewer then?
Oh, I guess let your office know that they're available, because we're always searching for people to do reviews.
Yes, please contact us, that if you want to be a peer reviewer. We definitely have a lot of trials that are looking for the investigators that can be the peer reviewer, and especially if you're new to this field, then, and I think Joe, you offer to also mentor some of the new investigator too, right?
Sure.
Yeah. Okay. So I think that's all the questions that we have, and just thank you so much for Joe for this conversation. Let me just get back to James. So James, do you have anything else that you would like to ask us?
No, I don't have any additional questions. Your conversation was very insightful. Thank you again, Dr. Pater, for joining us for this new session of Chat with the Chair. It was very informative.
Pleasure to be here and enjoyed talking with you.
Thank you. Yeah, so we've reached the end of today's session. So I'd like to thank Dr. Toren and Dr. Pater for sharing the knowledge and expertise with us today. And I would like to thank all of you that have taken time today to join our virtual round session. We will be sending out certificates of attendance to all the attendees who joined us today by email. And we'll be posting the recording of this session on our website and be circulating it through email as well. Thank you, everyone, for joining us today.
Thank you.